McKinleyville.
In McKinleyville. There's
Yeah, I know what you mean.
and there's also the community center. There's the D Street Neighborhood Center and the community center in Arcata. Yep, we could have
Okay.
a meeting on the plaza. What? There's
A lot of comments from the public at that meeting.
Right on.
to look for.
Hi, Colleen. How are you today?
You know, I'm good. I was just wondering, I was put down as absent on the meeting last month and not excused. Remember, I had to travel to Montana because my brother was critical and has since passed.
Oh, yes. Okay. I don't think we entered that as excused. So when we do the minutes, approve the minutes, let's make that adjustment. Okay.
Okay, thanks. Thanks, Tim.
Thank you for reminding me about that.
Hey, everybody.
Joe, do I remember right that Connie and Emmy are down in Orange County?
Emmy is back. I'm not sure about Connie.
Okay. I did get a connection from Tim Ash. He has an appointment from 11 to noon and may be late in joining us. Paul, you always look like an airline pilot by wearing those things, you know.
Thank you. I have much respect for airline pilots.
Okay, good. I'm going to get us started. It's my clock says it's 12:16. So it looks to me like we have enough board members for a quorum, but we'll double check that when we do the roll call. So I want to welcome everybody to the monthly Behavioral Health Board of Humboldt County. And we are an advisory board for the Board of Supervisors. We hold these meetings on the fourth Thursday of each month, and it runs from 12:15 until 2:15. The minutes and the agenda can be found by Googling Humboldt County Behavioral Health Board. You will find such information within a list of the committees. This is a public meeting, and everyone is invited to attend. We provide time for public comments in the beginning, and I will say more about this when we get there. Please note that this meeting is being recorded, and if that is a difficulty for you, then please let us know when you share, particularly talking to members of the public, and we can turn that recording off for you if that would be something you would like to happen. We start every meeting with a roll call of board members and then introduction of staff and then members of the public. We invite you to share your name, but you're not obligated to do so. We shall also allow time for those speaking to inform us of their preferred pronouns. So let's get started. Joe, you want to give us the roll call for the board and give us time to say our preferred pronoun.
Alyssa Norman,
Here, she, her.
Laura Montagna,
Laura, just Laura.
I have to.
Steve Madrone excused, Tim Ash, late. Jim Doty,
Here, he, him.
Madison Flynn, Allison Tans,
I'm here, she, her. Thank you.
Debbie Hartridge,
Here, she, her.
Colleen Broderick,
Uh,
I think they
Here,
Calls my-
she, her.
Isabella Wotherspoon, Danette Kellerman,
here,
Vernon Price,
Here.
Gardner Carlson, Oscar McGowan, we do have a quorum. We have 8 members.
Okay, thank you. Let's go for an introduction of staff. Why don't you go ahead and start, Oliver, and then we'll go down to everyone else, okay?
Yeah, definitely. Hi, everybody. My name is Oliver Gonzalez, pronouns he, him, and I'm the MHSA coordinator here for Humboldt.
Hi, good afternoon. Emmy Botzler Rogers. I'm the Behavioral Health Director in Humboldt, she, her.
Hi, everybody. Paul Bugnacki, Behavioral Health Deputy Director, he, him.
This is Jack Brazil, Behavioral Health Deputy Director.
Hi, I'm Jeremy Nilsson, he and him. I'm the Deputy Branch Director over Children's Behavioral Health.
Any other staff members?
Yep, I'm Alex Oliveira. I'm a MHSA QI admin analyst, and my pronouns are he, him.
Okay, thank you, Oliver.
Hi, I'm Kristen Smith. And she, her pronouns. I'm a senior health education specialist in healthy communities at Public Health.
Hi, Chris Messenger, DHHS Communications.
Hi, everyone. Sonia Levy-Boyd, she, her, and I supervise the Humboldt County Transition Youth Collaboration and the peer coaches at the TAY Division.
Hi, my name is Danette Kellerman. I'm a social worker for Humboldt County Conflict Council.
Hi, I'm Kathy Rigby, she, her, working extra help in behavioral health.
Hi, I'm Laurel Johnson. I'm an analyst in DHHS admin. I go by she, her.
Good afternoon, Melissa Chilton. I'm a budget specialist for County Behavioral Health, she, her.
My name is Aaron Zell, Behavioral Health Analyst. Pronouns are he, him.
It looks to me that the staff has introduced themselves. This is time for members of the public. If you'd like to introduce yourself, please do. You don't have to.
My name is Katie Wilson. I'm a local psychiatrist.
Thank you.
Jacob Rosen, Managing Mental Health Clinician for the City of Eureka.
Thank you. Want to give everybody a chance, but I hear no other members from the public at this time. So are there any adjustments to the agenda? Colleen?
I am listed as absent last meeting, but I was excused.
Okay, we'll do that at the approval of the minutes, but we will do that.
Okay.
Any other adjustments to the agenda? All right, it's time for public comments. I do want to let everybody know that this is a public stakeholder meeting for the Mental Health Services Act as we prepare our 3-year plan, and that will take a large part of our agenda. And there will be opportunity for comments at the end of that presentation for all members from the public. So this is the time now, again, for public comments at this time. And I ask you to keep it to 3 minutes and keep it respectful.
Hi, Tim. Katie Wilson here. I have just one thing, but it doesn't need, I don't need to be first. If there's anyone else from the public that wants to give input, it's, fine with me.
No, why don't you go ahead?
Okay. My only thing was going to be to ask the BHB if there's a time in the future, at a future meeting, where my recommendations that I presented in the letter on November 6th could be discussed.
All right, thank you. We'll take that up with our next executive committee meeting, which will be in January, and we schedule those agenda items. So thank you.
Great.
We will. Okay.
Sounds good. Thank you.
Anyone else from the public who would like to make a comment at this time? All right. Thank you very much. Number 5, our first action item is the approval of the minutes from the 10/27/22 meeting. You're up, Colleen.
Oh, I would like to be moved from absent to excused. I had discussed my absence with Tim.
Okay, thank you. Laura.
I would like to move that we accept the minutes as presented with the change of Pauline Broderick being member present.
Thank you. Is there a second for that?
I'd like to second that.
Well, way to go, Alyssa. All in favor say aye or raise your hand. Okay. All right. It looks like it has been passed. So that's the one action item that we do have, and we'll have opportunity for reports, communications later. But at this time, I would like to turn over to Oliver Gonzalez for the presentation of stakeholders meeting. It's all yours, Oliver.
Hi, thank you. Let me share my screen real quick. Are you guys able to see this fine? Yeah.
Yes.
Perfect. So welcome to the stakeholder meeting for the Mental Health Services Act 3-year plan for 2023 and 2026. I'm Oliver Gonzalez, the new MHSA coordinator for Humboldt County, and I appreciate you being here today. I would like to first thank the Behavioral Health Board for hosting my very first stakeholder meeting. I am pretty new still, 2 months into my new role here, and it's just been a huge learning curve. So again, thank you for the opportunity of hosting this first meeting for me. With that said, since I'm still pretty new, I did want to give everybody a heads up that I'm still learning a lot of the components. At the end of this meeting, you may have questions for me, and there's a good likelihood that I might not have the answer right away. I still encourage you to ask those questions, but I just wanted to give you guys a heads up so that way I can at least research that information and send you the information that you need for your answer. Okay. So then, okay. So a couple of items to go to before I get started. I'd like to ask you to complete the MHSA demographic form. The link is here in the slide, but Alex is gonna be sending it in the comments as well. I'm actually going to show you the form right now so that you can see it. Okay, is everybody able to see this fine? Perfect. So this is the demographic form. It's asked for very basic information. If you guys see all the way in the very end, there is a section for comments as well. So if any comments you may have, or maybe after the meeting, you didn't ask me something, this is your chance to do it as well. Okay. Information provided on this form helps us a lot, especially it tells us who was reached. Completion is voluntary and anonymous. We won't know who submitted these forms, so don't worry about that one. Perfect. So then I'll move into the next slide. So I briefly touched upon the demo form. The other way to do comments is through email. The MHSA comments at co.humboldt.ca.us is actually a really good resource, and Alex and I check that periodically. So Alex is going to be dropping that email link as well for you in case, again, you guys want to utilize that as well. Also, the other thing is Alex is going to be taking notes of everything that's mentioned in this meeting. So, and all of that will be recorded for sake of making sure we are updating our plan accordingly. And I do want to stress the fact that this comments should be reserved specifically to the 3-year plan that we're going over today. Okay, so with that in mind, let's get started. So this infographic right here that I have for you, the history and purpose of MHSA. So MHSA was created through Proposition 63. It was approved by voters in 2004 and enacted into law January 1st, 2005. As you guys can see, it places a 1% income tax on Californians who make personal income of above $1 million. Funds are collected, like in the blue bubble right here. They're collected, and the California State Treasury places them into the Mental Health Services Fund. Okay, 5% of that are allocated to state agencies for administration. These 5 agencies are DHCS, which stands for Department of Healthcare Services, CBHPC, which is the Behavioral Health Planning Council, HCI, the Department of Healthcare Access and Information, MHSOAC, the Mental Health Services Oversight and Accountability Commission, and DPH, which is our Department of Public Health. All the remaining 95% of the funds are then distributed accordingly to the 58 California counties and 2 city jurisdictions based on a really fancy formula that they have, but that essentially uses population density to make a determination as to how much money goes to each county. Okay. So with all of that money in mind and the funding, what exactly is the purpose? So these funds are intended to expand best practices and recovery-focused mental health programs. They reduce long-term negative impacts resulting from untreated mental illness, and they also prevent mental illness from becoming severe and disabling. So as far as county requirements for MHSA funding and how they're allocated, we are required to complete a 3-year plan every 3 years. Since 2005, there have been 6 3-year plans, this one being the 7th. Most recent was the 3-year plan for fiscal years 2020 to 2023, and that was approved 3 years ago. In between 3 years, we're also required to do 2 annual updates. Plans and updates require a community program planning process, which is set for Section 3300 of the California Code of Regulation. Okay. So as far as this community planning process that I just mentioned, the CPPP, so stakeholder participation includes representatives of unserved and or underserved populations and their family members. Stakeholders reflect the diversity of the demographics of the county, including geographic location, age, and race and ethnicity. Stakeholders are individuals or entities with an interest in mental health services in the state of California, including but not limited to individuals with serious mental illness and or serious emotional disturbance and their families, providers of mental health, educators and or representatives of education, representatives of law, and pretty much any member of the community that's involved in mental health services or just is curious. So this portion right here, I'm going to be going briefly through the programs planned in the supported 3-year plan. First, I will show you the 3-year plan itself. So I'm actually gonna get out of this real quick and show you the 3-year plan and in its beautiful entirety. As you will see, there is a table of contents here that has a breakdown of each individual plan or program with its specific components. If you haven't seen it yet, I recommend you do so because it gives a bigger breakdown of what our programs do, especially for fiscal year 2021 to 2022. Okay. It resetted me. Sorry about that. Okay. So of the 17 programs planned to be supported in the 3-year plan, 12 were approved in the 3-year plan annual update from previous years. 5 are actually new, and I will indicate the new programs when we get to them. So here is an overall hierarchy kind of a slide that gives the overall funding that we're planning for these 3 years. I got to give a special shout out to Melissa. She's the one that gave me the right number. So Melissa, I know you're here, so thank you. So as you can see, the total estimated available funding is $39,318,053, with community service and support accounting 71% of those funds, or almost $28 million. Innovation is almost $3 million at 8% of these total funds. Prevention and early intervention, also known as PEI, is a little over 8 million, and that's accounting 21% of total funds. And then workforce education and training, which is WET, is accounting for less than 1%. So community services and support, CSS, what do they do? These are our programs: comprehensive community treatment, full service partnership, regional services, older adults, independent adult program expansion, and crisis residential treatment. Full service partnership, comprehensive community treatment, accounts for 85% of CSS funding, estimated at $23,906,869. It provides intensive community services and supports like housing, medical education, social, vocational, rehabilitative, and other needed community services as defined by a client partner to decrease hospitalization and achieve recovery. In the report that is in the 3-year plan, you may see that they're estimating to service 216 individuals in total. Regional services, so that's around 2% of total CSS funding, estimated at a little less than $500,000. They reaches out to engages adults living in the outlying areas of Humboldt County that have a scarcity of behavioral health services and provide services to them as needed. They're estimating to serve 50 individuals per year, so that's around 150 new individuals for the 3-year plan. Older adults, independent adults, accounts for about 1% of CSS funding, estimating $234,534, provides in-home services to disabled adults, at-risk adults, and older adults. Services include outreach, education, assessment, and treatment for older and dependent adults with mental health challenges who are at risk of abuse or neglect, or who are in need of support services to remain in their home. Estimated is 150 individuals to be contacted just for our fiscal year 2023-2024. Other estimates for other years, kind of impossible to gauge that one, unfortunately. Crisis residential treatment. So this equates to about 9% of total CSS funding, estimating almost $2.5 million. Will provide crisis residential treatment to DHHS behavioral health referred clients approximately by fall 2023. I know Jack's been really working super hard on this one. They're contracting with Willow Glen for this program, and they acquired a property in Eureka that is undergoing remodeling efforts. So it's really exciting to see them progress. They have about, in total, 9 beds available for DHHS clients. Innovation. So we only have one innovation project for this 3-year plan, and that is REST, the Resident Engagement and Support Team. Estimated is $1.4 million. Increase is meant to increase case management and peer support for those experiencing homelessness or at risk of becoming homeless. Estimated is 100 individuals to be served annually, and this was approved by the MHSOAC in January 2021, and limited services to clients began July 2022. So now we're reaching the prevention and early intervention PEI component of MHSA. And this includes the Hope Center, Transition Age Youth Advocacy and Peer Support, suicide prevention, parent partners, local implementation agreements, school climate transformation / multi-tiered system of support, suicide prevention hotline, and there's new incentives. Those new incentives I will get to at the end of the PEI section. So as you can see here in the Hope Center, it equates around roughly 13% of PEI funding, estimated at around a little over $1 million. And they provide a safe, welcoming environment based on recovery, self-help principles, and resources for people with mental health challenges to be self-sufficient. It's a peer-run and includes peer-to-peer education and support, system navigation, and linkage to services. Now, then we have Transition Age Youth Advocacy and Peer Support, which is around 13% of the PEI funding, estimated at a little over $1 million. Provides activities and peer support for youth and young adults ages 16 through 26 that are responsive to their needs, fostering youth development, advocacy, community engagement, and promoting your youth wellness. They're estimating around 200 individuals to be served. Suicide prevention. We have 8% of it accounting for PEI funding, estimated $681,157. Training such as question, persuade, and refer, QPR, and living work start are provided. Suicide fatality review facilitation, lethal means safety, which is more of like gun safety in that sense, collaboration with the Humboldt County Suicide Prevention Network and other community coalitions, and also social marketing. Parent partners, 11% of PEI funding, estimated a little less than $1 million, aim to build peer-based alliances by sharing lived experiences as a parent, caregiver of a youth with mental health issues, offer assistance in navigating the DHS system, linking parents and caregivers with community resources, building natural support, and helping them identify their personal wellness. We're estimating 90 individuals to be reached just for fiscal year 2023-2024. Local implementation agreement. So this equates 4% of PEI funding, estimated at $360,000. Provides opportunities for community-based organizations to apply for funding for projects that meet the PEI guidelines. Projects currently approved are the Bear River and Runner Rancheria Seeking Safety Community Wellness, Two Feather Native American Services, development and implementation of cultural programming for youth and parents of children 0 to 5. Humboldt Independent Practice Association, mental health prevention through student empowerment groups. Now we have School Climate Transformation, Multi-Tiered System of Support, MTSS. This equates 3% of PEI funding, estimated $260,323. Contracts with the Humboldt County Office of Education. They support the prevention and intervention specialists to manage, develop, and coordinate services for the MTSS, which assists school personnel in adopting and organizing evidence-based behavioral intervention into an integrated continuum that enhances academic and social behavior outcomes for all students in Humboldt County schools, essentially. Then we have the North Valley Suicide Prevention Hotline. Less than 1% of PEI funding, which is estimated at $51,858. It operates a 24/7 suicide prevention hotline to answer calls, maintain a hotline website, and provide outreach and technical assistance to participating counties. And lastly, as we mentioned, the new initiatives proposed under PEI. We have the Latinx liaison position for Humboldt County, the early childhood treatment certification, warm line, suicide prevention through behavioral health quality improvement initiatives, and PEI assigned funds through Cal Mesa statewide PEI program. So the Latinx liaison position, it's roughly 4% of PEI funding, estimating a little less than $280,000. And in essence, it's a behavioral health incentive to recruit, hire, and train a Spanish-speaking, culturally proficient individual to provide outreach and act as a liaison to Hispanic, Latino, and Spanish-speaking communities within Humboldt County. And also it's meant to promote an understanding of services and awareness in provider availability. Early childhood treatment certification, around 4% of PEI funding, estimated $354,750. It's a certificate training program designed to better equip local community mental health providers with knowledge, skills, and confidence in treating mental health issues within young children populations. Their goal is to certify a total of 24 individuals within a 3-year time span. Warm line, 4% of PEI funding, estimated $306,486. A phone line service created during the COVID-19 pandemic to connect community members with non-emergency mental health counseling and support. Available to the community regardless of any insurance type or association with county behavioral health. An opportunity for early intervention that can prevent more acute, intense crisis experiences. Then we have the suicide prevention, behavioral health, quality improvement initiatives. 2% of PEI funding, estimated $160,000. It's supposed to be a consultation support tailored to support system improvement needs associated with suicide prevention, assessment, and training. The timeframe for this initiative ranges from 12 to 24 months. PEI assigned funds, Cal Mesa statewide PEI program. This is integrated within the total PEI budget, hence why there's not a specific dollar figure assigned to this one. The HHS behavioral health participation in the statewide PEI program. This will support activities for behavioral health branch that will aid in stigma and discrimination reduction, also known as SDR, will improve access and support of mental health services, will develop local and statewide capacity building support, and improve outreach to community stakeholders. And then finally, we have WET, Workforce Education and Training. Estimated $207,368 for Realize e-learning systems. Provides staff development opportunities that promote wellness, recovery, resilience, and culturally competent service delivery. Also participating in the Super Regional Partnership Program, which is around $17,000 to provide opportunities to increase and retain behavioral health workforce. So you may be wondering, what are the next steps as far as the 3-year plan goes? And here is a brief outline. To continue with community meetings and gather input. You guys are number 1, so I got like at least 14 more to go, I think. Prepare report from the community meetings and present to the Behavioral Health Administration. And that's not going to happen until way down the line. Changes may be made to the drafted 3-year plan based on administrative decisions. The 3-year plan will be posted on the county website in the future. A 30-day comment period will begin in the future as well. Public hearing at the end of the comment period. Changes may be made to the 3-year plan based on comment period and public hearing. 3-year plan will go ahead to the Board of Supervisors for approval. And once that happens, the 3-year plan goes to the California Department of Healthcare Services and Mental Health Services Oversight and Accountability Commission for final approval to the state. Now, you might be saying, wow, that's a lot of text. Can you give me a visual? And I say, you got it. So here is a visual of it. As you can tell, we are literally just on the tip of the iceberg right here. We got a long way to go, and honestly, a big learning curve for me. Really looking forward to it. I'm gonna leave this slide on for a quick moment in case you want to see it a little bit more. But yeah, I'm really excited to be part of it, and thank you for sharing this journey with me. And I look forward to whatever comments you may have for me.
Well, I certainly have lots of questions and comments.
Yeah, no problem. Go for it.
Tim, you're muted. Sorry.
Laura, you're a little garbled on it. I just want to say this is a time for comments and sharing. Particularly want to hear as many people as possible, so that will be guiding my facilitations on this. So, Laura, fire away.
Okay, you sent us a piece of paper that had current programs, which I think is similar to what you just showed in the PowerPoint. But the numbers are very different. And my question to you would be, I was trying to see if that was because they were single year and your PowerPoint is for 3 years. Is that true?
Yeah, that's correct. So that document that you're referring to only reflects fiscal year 2023, 2024, so just 1 year.
Okay.
And the reason we did that was because budgets do tend to change a lot, and this budget is such a draft that it didn't seem practical for me to create one that reflected all 3 years like that.
Okay, so is there a way to get, I think it's really important to know the program cost and number of people served on every single item.
Mhm.
That's one thing. And if we're gonna go by year, because it's confusing when you have 1 year here and 3 years here. But just clarification on that.
Absolutely. If I may say, if opening the 3-year plan, the very last portion of the 3-year plan actually has a breakdown that's itemized per service of each individual year as well.
Okay, and then I'll ask like one more question and then let other people, and then I'd love to come back because I feel like this is our chance.
Yeah, go for it.
So there's 2 questions. Trying to find out about REST, the Resident Engagement and Support Team. I'm not aware of where that is and how to access that because I haven't come across it.
Yeah, that's we're talking REST, right?
Correct.
The resident? Okay, yeah. Honestly, I'm not well versed on REST, especially because it is a program that's still in development phases. I know Jack is on the line. Jack, sorry to put you on the spot, but would you be able to share a little bit more about REST?
Yeah, sure, I'm happy to. So REST is funded through innovation funding, and it was a program that we developed to help individuals who are recently housed. Basically, a lot of the folks that we had stepping down from like our home program that need sort of ongoing support and case management, we would be able to provide that. And so they provide that sort of level of care for our folks, case management services and for those individuals.
So is it only available to people from home or the community?
No, it is available if you've been recently housed, that you could get that. There are other entities that make referrals to that program.
Was it only referral?
What's that?
Is it only referrals? How do I get in touch with somebody from REST for a referral?
They would need to come, they would need to be like a behavioral health client.
Okay.
Okay, thank you. I want to be able to recognize that a board member, Tim Ash, is here, and that be put in the minutes. We also have another, maybe I missed it before, Aaron Zell is here with us as well. And I do want to make sure members of the public have an opportunity to speak up. But is there an echo?
Yes.
Is that coming from me?
No.
I don't know technical stuff. I don't know how it's happening. But
Tim, I'll just recommend that everybody who's not talking mute, including you, Joe. I'm not sure if you're aware that you're unmuted, but everybody should be muted unless they're speaking to decrease the feedback.
Thank you. Thank you. So another person who would like to make some comments or ask questions of Oliver.
This is Katie Wilson, and I have just one or two things to ask or say, but I don't need to do it in any particular order. So if the board members want to ask questions first, maybe is that the usual way?
No, that you're welcome to get started. I also want to recognize that Supervisor Madrone has joined us as well. No, Katie, fire away.
Okay, so I actually already emailed Oscar earlier this morning, and I CC'd everybody in this audience, so perhaps everybody's already seen it. But for one thing, I just want to really thank Oscar for all the work he's doing. You can tell that he's trying to make it extremely inclusive, and I really appreciate that. I put down that it'd probably be useful to also include the stakeholders in the criminal justice system. And so I put down some suggestions in that email, including the district attorney and the public defender. And, you could see it in the email. And then the only other thing I was going to put out there is I'm not sure, since Oscar's new, if he's aware of from my perspective, problems with the public process for MHSA feedback in the past. And that has been no one's fault, except that for whatever reason, the board and the public don't get actual data on the number of people being served. And for example, outcomes from people with or without different levels of support. And so I'm hoping that maybe this time for the 3-year plan, that since DHHS is having a new electronic health record, maybe it'll be easier for DHHS to actually sort of run reports on the actual data, like how many people were admitted to SV and what was their outcome, how many were readmitted within 3 months and 6 months, and what were the particular factors that either worked or didn't work. So that's all I will say, because it's also in my email. Thanks, Tim.
Okay, thank you.
No problem. Hey, Katie, I know that there was an Oscar as well in the email chain. My name's Oliver. Just as a heads up, I do want to.
So sorry. So I wonder if I sent it to the wrong person. If I did, I apologize.
No, you're absolutely fine. I still get the email, but I think you were referring for it to go to me. Also, as far as the comment goes with data and all that, I just want to say a reminder that this is an opportunity for the community to give input on MHSA, not necessarily for staff to report on programs and services. I do understand your point of view, Katie, but I just wanted to kind of voice that as well.
Okay, thank you. I saw a question on the chat. Well, go ahead, Colleen, and I'll get to the chat question from Laura. Colleen, you are muted, Colleen.
I'm referring to the services that were directed at elderly people on protection. And I was wondering, what is the referral agency that accesses those services? Is it Adult Protective Services, or what is the access point to be receiving those funded services?
Colleen, that's a really great question. Unfortunately, I don't think I have the answer to it. Does anybody here on the line know by any chance systemically how that works?
I do want to just comment that Oliver is the statistician. He's getting your comments and information about the Mental Health Services Act. If there's a particular program and how it would work, then I think we need to refer that to people here on the staff who might be able to answer that. So, but I think it's a great question. Colleen, would someone on staff like to respond to that?
Thank you, Tim.
Yeah, I can answer that one. So we have the older adult program that Oliver mentioned. Primarily, the referral source is going to be either internal or from APS. A lot of the folks that we work with are going to sort of concurrently have protective need issues that APS are involved with those particular folks, and so they would be, the ones to provide that referral.
So is that funding directed then toward that agency?
the funding is a behavioral health internal program, but the purpose of the program is to coordinate services with APS.
Thank you.
You're welcome.
Sometimes that's hard for us to tell on the funding where the money is coming from. And I'm sure it's hard for many of the staff, but that is helpful for us to know, like how much Mental Health Services Act money is going to that program and money from other sources. So that's my comment. Alyssa.
Yeah, it looks like we have some comments in the chat. It looks like Laura has asked, how does a new program get proposed?
Yeah, that's a great question. That's still something that I'm learning, and maybe Emmy might be able to give a little more input on that one. Sorry to put you on the spot like that, Emmy.
No, that's the purpose of stakeholder input. That's the purpose of this meeting. So we're sharing what we're funding and the work that we're doing. And if the community or individuals in this group have suggestions or thoughts about services needed, this is the time to say those, and so that we can record that and you know, consider all those suggestions.
And in fact, I mean, I could just add to that. That's how REST was developed. It was developed from MHSA stakeholder input. So the majority of the input that we received in the previous stakeholder process was about supporting individuals in that were at risk for homelessness or needed support within that were newly housed. So we developed that project and that program from that stakeholder input. So it's a direct result of this process right here that Emmy's talking about.
So
Thank you.
responding to this presentation is a good thing to do for when it comes to starting new projects.
Absolutely.
Okay, and then there's another question from Laura. There seems to be a redundancy with suicide prevention. 2 suicide prevention programs. Am I reading it wrong?
No, that is not wrong, actually. There is the current suicide prevention program that focuses specifically on services to prevent suicide prevention. And then the other is a proposal for an initiative meant for consultation.
Thank you very much, Oliver.
Katie, I see your hand, but I want to make sure other people have a chance to comment before we come back to you. All right.
Sure.
Anyone else from the community or the board? Debbie.
I didn't quite follow the 2 different suicide programs. One is for prevention, one is for consultation. Can you say more about that?
Yeah, at least for the consultation one, I can't really elaborate too much because it's such a new initiative, honestly. But it's through quality improvement, essentially, and they're wanting to improve overall service designs and communication within departments. As for that prevention, the other program goes, the suicide prevention one, that one's more for direct client services, as well as distribution of media and pamphlets and information as well, and trainings. I hope that clears it up a little bit more, Deborah.
I think I'll review it. You have it written down. Thank you.
No problem.
Thank you, Debbie.
Oliver, is public health still responsible for all of the suicide prevention material?
Hold on, Allison. I'm responding to hands that are up.
I'm sorry.
No, that's great. I'm glad to hear you, but I want to go with hands first, and Tim Ash is next, and I'll get back to you. Okay, Allison?
I'll yield a little of my time to Allison.
Okay, Allison, you're on the floor.
Sorry, and thank you.
No,
I was
worry.
just curious if the suicide prevention materials are still published and or gathered by public health and disseminated through them.
You know, I don't really have much knowledge of that. I can see in the chat that Kristen might be able to elaborate a little bit on that. So Kristen, you're more than welcome to, and thank you.
Sure. Hi, I'm with the Suicide and Violence Prevention Program. So originally the PEI funded side of it, and we're focused on prevention efforts for the entire community and county, whereas this proposal that is new is for an initiative at Behavioral Health Branch to make changes in their process and how they handle suicide. So it's 2 separate things.
All right, thank you, Kristen. Tim Ash.
Yeah, The first thing I want to know is this is not the best format for really getting everybody asking all the questions they have. It's a pretty broad scope program, a lot of programs within the MHSA. And I'm just wondering what the best preferred way of us asking questions to inform our comments that we have along the line would be. For example, there could be their proposal for a Latinx liaison. My question was, is this person going to be a clinician, and are there similar proposals for African American community, Native American, Pacific Islanders?
Who would like to answer that question?
That's a good question. So as far as the Latinx position goes, it's a pretty new idea, initiative. As far as whether it exists for other ethnic groups and communities, it does not. As it states in the 3-year plan, the Latinx position was an idea of the Community Responsiveness Committee from a year ago, and they're the ones that created and drafted a plan that suggests the need to develop somebody that can go into Spanish-speaking communities and do outreach, essentially.
Okay, Oliver, I see some chats on it, Emmy, and then maybe Paul. Emmy.
Well, I'm gonna just again try to maybe open up opportunity for this group to really think about, from your perspective, what you feel like is needed in our community. So we have the 3-year plan that everyone got to take a look at, and that's what we've been working on. And it includes programs and services recommended going forward. These 5 initiatives are things that community or staff have lifted up as areas of need. So for instance, Latinx liaison is something that has been long discussed in terms of access to the Latinx to that community. Early childhood certification, that came from stakeholder request around needing to focus more on young children and working more preventatively with early intervention. I would say if there are other areas, for instance, Tim Ash, where you think, gosh, we really need a liaison for the African American community, this is the time to say that. So this is the opportunity for everyone in this room to say, hey, wait, I feel like we need this service in the community, as opposed to evaluating whether or not those 5 are, instead of thinking, well, should we do this or should we not do this? Please share what you think we should do. Please share what you feel like is missing in terms of services and programs in our community that you feel like are really needed, so that we can write that down and have that recorded today. We want to make sure we hear everything you think needs to be included in consideration going forward.
So what I hear you saying, let's focus on recommendations.
Well,
Tim
we're
Ash,
also,
back to you.
I'm ready.
so am I muted? No, I'm not. Okay. I was just using an example. I don't have any real opinions on that. That was a question I have is it going to happen? I mean, I understand you would look at, well, the percentage of people in each demographic and make that kind of decision. But part of my question is it a person, a clinician? But that was just an example of questions. I have a bunch of them like that, and trying to figure out what, I have some other questions, but that's the first one. What's the best way to just ask those questions to inform any comments that we might have about, yes, I think, there is a need for this as well.
Are you asking a question for us to respond to that?
Yeah, the question is, how do we ask questions to inform our ultimate eventual comments on MHSA?
I have an answer to that slightly. Alex Oliveira has put in the chat that we can email all MHSA 3-year plan related questions to an email to be able to get some answers that way. So that is an option other than now.
So I just figured it would be good to everybody to be sent it to the same place and be the place that you guys wanted to go to.
Okay, thank you, Tim. This is one of the reasons why I wanted to have an informative meeting ahead of this meeting, because this is our one chance, and our time will run out if we don't say what we want.
I have 6 specific recommendations whenever people are ready.
I'm not quite done if I
back to
may.
Tim Ash.
So one comment I wanted to make in terms of data, as I looked at the proposals, for in the plan, it seems like, and maybe I'm just missing it, but there's have things like penetration rates, but what I don't see in there is effectiveness measures. It's one thing to say that we see 60 people in this program during the course of the year. It's another to say how many had changed behaviors or change outcomes in the community. And I'm wondering if that's there and I'm missing it, or if there's been any attempt to try to work on how we could figure out how these things are effective. Like AOT, for example, they measure the reduction in hospitalization and incarceration. To me, that's far more important than saying, hey, there's 15 people in the program. So anyway, that's a question. And I'm wondering, am I missing, has there been any consideration of AOT being part of the PEI program, putting some of the money for that? And the reason I ask that is it's currently general plan funded, and that's kind of, up to the political winds, maybe more than a thoughtful program for mental health in the community. And the other thing was, is there any chance we could get I think I've seen a pie chart, I don't know if it was in it this year, but pie chart showing how much money is going to what, and also what changes have been proposed from the last 3-year plan to this year 3-year plan. Just kind of see, this is a new one. And I know some of that will be obvious, but just to understand what we should be focusing on to some extent.
Who are you asking?
Whoever wants to answer it.
I can respond just quickly, Oliver, and you can then add to it.
No problem. Thanks, Annie.
The primary changes being proposed are the 5 on the slide, the new initiatives that Oliver pointed to. Those are the changes. I think that we do have pie charts. I don't know if it's in the current plan, we could certainly share that. That's an easy thing for us to do. All programs have some measures in addition to just numbers served that include, outcome and quality of service and input on that. So much of that is in the 3-year plan, reported out in the 3-year plan. So I would just recommend or suggest or encourage reviewing that again to see if you can find those details. And then if there are additional questions, certainly you can lift those up. AOT, I'll just remind this group, we're not allowed to fund AOT with anything that would reduce voluntary services. And so we can't just start using MHSA funding for that. That was part of what we took to the Board of Supervisors when we presented quite a while back now about whether or not we should move forward with AOT and what funding options for that were.
Have you confirmed that with MHS AOC? Are they still of that opinion?
I'm not sure the question. It's very clear that you're not allowed to reduce voluntary services to pay for AOT.
What's your understanding of what people are doing around the state?
Can I ask this question to go out of this meeting, Tim?
Sure.
Okay. Thank you. Katie, and then to Alyssa. I don't see other hands, but Katie, you said you have what, 6 recommendations?
I do, but they're just the ones that were in my letter that I wrote to the board and the Board of Supervisors, et cetera, on November 6th. But since Emmy is inviting us to give specific ideas, I'd be very happy to share them briefly. The first is that I think that DHHS should review the 5150 statute interpretation and how they respond to psychiatric emergencies. And so perhaps that could be incorporated as a innovation or a new thing, because to me, there's problems with how critical decisions are made during psychiatric emergencies. The second is to give patients actual medications when they leave SV or the jail, rather than prescriptions that they often don't end up getting filled. The third is to use long-acting injectable medications for everyone that has a history of medication non-adherence, unless it's specifically contraindicated, because this is the most modern way to help people with anosognosia stay in treatment, and also to prevent future psychosis, which causes brain damage and ongoing problems with people. The third is that if a particular caregiver, such as a visiting nurse, is no longer available, then a different one should immediately be assigned. And there should be a case manager through DHHS that's coordinating the care for each of the patients. Multidisciplinary treatment teams should be used and have been used in the past. And for patients with anosognosia that otherwise fall through the cracks of community services, and that the psychiatrist that's treating those patients on that team should be participate in those treatment team meetings.
I'm going to interrupt, Katie. Are you recommending for Mental Health Services Act money to go to any of these?
Yes, I think
Okay.
these are all critical. I mean, from
Well,
my
I
perspective.
I understand they're critical, but I'm just asking that question of how
Yes,
the
I
funding
am.
is.
I
Okay.
am indeed. And the reason is because these are the patients, the 50% of patients with anosognosia
Okay.
all across the country that aren't in treatment because they don't know they need treatment. And those are the very most ill patients.
I
The last
understand.
thing, and the very last thing I said, and I've been floating this idea and I have not received a response, is that I believe that we should have an urgent psychiatric walk-in clinic in which patients could be seen without appointments that need emergency medication adjustments or refills, or they're in an urgent psychiatric situation. And I've offered to help with running that. The DHHS had one like 15 years ago. I was involved in it. I take no credit in starting it or anything. I just happened to be the psychiatrist that worked on that service. And I am willing to do that again if there's no other way to get that service done until there's more methods for that. And I would guess that urgent walk-in services for psychiatrically ill patients could definitely be fit into MHSA funding. So
Thank you, Katie.
that's all.
Thank you. I see Alyssa and then Danette. I see your hand up, Tim. Are you ready to come back with something, or? I'd like to go on to Alyssa and Danette. Okay.
Okay, so what I'm thinking about is culture, and in MHSA, a lot of it is going towards, cultural competency. I think that there's still a lot of us and them communication as we're talking. I think that a lot of the peer positions are seen as, individuals who have experienced severe mental challenges, mental health challenges, and there's not enough uh, uh, there's not enough emphasis that individuals who live and work day to day in the community at DHHS experience mental health challenges. I think that the fact that 20% of a population experiences some sort of disability in a life, and that we many of us will encounter mental illness in our lives, either in part or in whole. There's just too much outsider talk still going on. So when you guys mentioned the Latinx position, I was really excited. I was like, that's fantastic. But I would like to suggest that something else to look at is like a whole contingent like of professionals in our community who have lived experiences and are doing very well, who represent different communities, not just like you said, also, Black community, LGBTQIA community, disability community. I know that that's talking about adding a couple more positions for individuals to do outreach and to be able to do educational information about what the different communities experience and what will benefit those different communities and what sort of outreach will bring them in more. But I'm hoping that maybe something like that can happen. That would be really awesome. And that's all I have to say, except for there's one more question from Laura in the chat. It looks like Laura asked, do the new programs have to be under DHHS as an agency, or can they be an outside agency that fills a need?
That's a really good question. So typically under MHSA, they have to be under the behavioral health umbrella. There is a local implementation grants as well, which kind of opens a little bit more of community partnerships around the area as well, kind of like the tribes and like Bear River that I mentioned as well. So through local implementation, there's definitely some more flexibility.
We also,
ahead.
sorry, Tim, we also do funding through MHSA of other programs. For instance, we have a partnership with HCOE, Humboldt County Office of Education, for their school climate curriculum and a position they have there. So we do have flexibility to fund other in other ways.
So again, to this meeting, we make a recommendation, and if you follow up with it, it could be done with partners, the way you would see the best way to do that. Is that? Okay, thank you. Danette, I lost you for a second. Glad that you're here. Please unmute yourself and talk to us about your recommendations or thoughts.
I apologize. I'm transporting clients while I'm in this to their appointments. I'm in the parking lot by myself. So I just a couple of things. I mean, it's great to implement all these different things. But I'm kind of concerned about how we're going to motivate people to actually work in this field, and how we're going to maintain people to work after they're hired to do those positions. Because we can hire a bunch of people, but a lot of people lose motivation. And I don't know about anybody else, but I sure get told a lot of places that I take my clients, we're short-staffed. So how are we going to maintain some employees to work in these positions?
Yeah, okay.
That's my concern. We can make all the plans and all the programs, but how are we going to hold on to people working in this field?
Okay.
That's my question.
Someone want to respond to that?
Well, I can just reference
because we have.
Who wants to speak? Danette, you have a follow-up? Oh, okay, let's let Emmy answer then.
I was just going to say, yeah, I absolutely recognize the challenges with recruiting and retaining staff. That's for sure an issue that we're working on in multiple ways. But one of the ways is through the WET funding, the regional WET funding work that we're doing, where we have money available to provide stipends or loan repayment or other incentive funding to get individuals both interested in working for the county, but also getting some financial support to remain in their position with the county. And you're right, Dana, it is an ongoing challenge that we'll continue to strategize about.
Follow-up comment, Danette?
I'm good. I just wanted to talk about that because it seems like we're making more and more programs, but we have less and less people working for the county. And it's just my perception. My grant in my position is coming to an end soon. So, I just think about how many other people are in these grant positions, and are we going to retain them? What are we going to do? You know, just people lose motivation in working in this field after a while. Like, I think they get burnt out or whatever it is, but you know, maybe some self-care incentive would be great too, you know. Anyways, thank you.
Thank you, Dana. I have a recommendation, but I want to give others a chance. I recommend that we seek more therapeutic counseling, mental health therapeutic counseling. And because I think it's serious, if we're dealing with serious mental illnesses, providing them with support, providing them with workforce advice, life skills advice, general case management, all of those are good things. But if we do not provide them with a therapeutic counselor, a trained therapeutic counselor, then I think we're going to fail. And so if there was some money from Mental Health Services Act that could be focused all of the different programs, but to provide us more mental health therapeutic counselors, that would be my recommendation. Allison, I see your hand up.
Yeah, and something that we recommended last year was supervisor training, like a minimum of 80 hours. I know when I left DHHS and went over to the CAO office, I attended Cascadia training, which was an 80-hour course. And then when I left the county and went to the state, I received 80-hour supervisor training. Like, that was one of the first things I had to do within 6 months. I just feel like the supervisors at DHHS need more than what they're getting. Like, Relias is great. I set up the contract for it, but I really believe that some sort of interactive training where people can work through, you know, situations and have some feedback on what they're learning and communication back and forth would be extremely helpful. And I think that could raise morale for supervisors and give them an incentive to stay and to, like, you know, last those 3 years until they're eligible to be a supervisor if they're a clinician or whatever else it is. So that would be my recommendation for MHSA funding. Thank you.
Thank you, Allison.
You're welcome.
Alyssa, I see your hand up. I want to make sure others have a chance. I don't see any other hands up at this time.
Oh, it's about the chat.
Oh, okay.
Okay, so Tim Ash said he was still curious whether Latinx liaison is proposed to be a clinician. Also, is DHHS interested in hearing proposals for new programming at this point? Emmy responded, the Latinx liaison was recommended as a case manager, and yes, this is the time to please make recommendations. And then Laura has also commented that this is workforce education, that is what workforce education training is for. Comment to Danette, let's recommend something.
Okay, thank you. Tim Ash, I see your hand up.
Yeah, a couple things. One of them is I'm wondering if anyone looked at our annual report in trying to get some input about potential new programming, and also I didn't mention earlier if there was any discussion or potential for having any new elements of a first episode psychosis program. We do some work in that area, but we're not really, you know, not doing it faithful to a evidence-based program. What if there's any thought about kind of beefing that up? And then finally, excuse me, just wanted to just clarify that this is not, today is not our last opportunity for input. It's just the first. I personally kind of look at it as scoping, but it's a kind of our first opportunity for input.
Tim, I think you're muted.
I was done.
Tim Doty, you are muted.
Thank you very much. Is that what you were trying to tell me, Debbie? Okay, thank you. Other questions, comments, recommendations? All right, thank you. Everyone, I'm going to kick it back to you, Oliver. I think that's where we are. Do you have any more things to say or guide us with?
No, I believe you guys provided amazing feedback, and I'm really looking forward to what else comes up in the emails and also in the demographic form. As a reminder, if you guys could please fill it out, that would be heavily appreciated, especially because we have such a broad, diverse population here, representing many people. That'd be amazing. Yeah, I would really appreciate that. So thank you. And thank you for the opportunity of being my first stakeholder meeting.
Thanks, Oliver.
Thank you very much, Oliver. Welcome to the team.
Thank you, appreciate it.
All right, then.
I'm hoping that we can get the PowerPoint sent to us from Oliver.
Oliver, can you send the PowerPoint to us all, or is that what you mailed to us?
I emailed the 3-year plan. I haven't sent out the PowerPoint. I do want to say that the PowerPoint is subject to change based on the funding as well. So that's something I have to clear up with Emmy first. Emmy, sorry to put you on the spot, but are you okay with me sending out the PowerPoint?
Yeah, that's fine.
Okay, cool. Then I'll go ahead and send it to Joe for distribution. Thank you.
Thank you. Thank you. Any other comments, questions? Debbie?
This is just a comment, but in the plan, I'm impressed to see that the full service partnership outcomes are looking really pretty positive. I mean, they're positive. It's just, I see that you are keeping track of rehospitalization and jail being back in criminal justice system in terms of outcomes for the full service partners, which that's great. It's looking good there.
Thank you, Debbie. Yeah, they're absolute rock stars, each and every one of them.
Thank you, everybody. We'll move on with our agenda. As we've said, there are more times to comment, and you can email your suggestions and comments. So we're going to move on with our agenda. Number 7 is communications, and these are things from board members who would like to communicate with us about things they like us to hear about mental health services, mental health acts. Any communications from the board? Laura?
Trying to multitask here. There was a letter sent to everyone asking to a letter of support for the CSET care team. And so, and that's something that would be needed fairly quickly. And so I was wondering, how do we deal with that?
Any comments on that? I was thinking, Laura, that the executive committee might find a way to look at that. We like a little preparation. Everybody has seen it, right? It's been emailed to everyone. So we can't vote on anything that isn't on the agenda yet. And so that would be my thoughts at this time. Tim Ash, I see your hand up.
Yeah, I was just going to ask when a letter would be needed, and how critical it is that you get one.
I think they needed it by next week, 11/26.
Hi, this is Jacob. So I sent a letter requesting the support. We're in the process, Uplift and CARE are in the process of applying for the HHAP grant, which is going to be providing funding for rapid rehousing and homeless and permanent housing, homeless outreach and that sort of thing. And that is due on 11/28. And we're hoping to have the letters to be able to submit on the 23rd. Preferably before the holiday. I realize that's short notice. My apologies. We got started late.
Tim,
yeah, I didn't read the letter, but I glanced and I saw it. And the quick glance, I'm sure that as a board at some point we could probably support that. All I can say is, like Tim said, we can't do it today. Tim, I don't really think the executive committee exists in a form where it can make recommendations. Also, who's the grant for, Jacob? I mean, who's it being applied to?
So HEP is available to various programs within the county, and Uplift and CARE, Crisis Alternative Response of Eureka, are filing a joint application. There's also an intent to have some funding for collaborations on job training projects and shelter projects with Betty.
But who's the grantor?
Where's the money coming from?
The grantor. That I believe is coming from the county, and the Board of Supervisors is the one doing the final approvals and review.
Okay, that's great, because we really are not supposed to do anything but advising the Board of Supervisors and DHHS management, and that fits. We can't write a letter to the legislature, for example, but we could do that. I will just say, for my part, I would be willing to meet for that sole purpose, a quick meeting to approve it.
Okay, Tim, I only meant for the executive committee to put it on the agenda. So if the board would like to have a special meeting to review this and make a recommendation, is that a motion, Tim?
Yeah, just to be clear, I mean, our next meeting is in January, so the only way we could be helpful would be to meet as soon as we can meet prior to the 28th.
Okay, Laura, I'm going to go with Laura and then Colleen.
I thought that we could do in this situation in the email recommendation, but
we can carry out a lot of business with email, but I don't know if we could do it this way. I don't know enough of if the bylaws have changed on this. I just don't know.
No, we cannot.
Okay, thanks, Tim. Colleen, I see your hand, and then I see your hand, Debbie. Colleen.
You know, I observed the Uplift program as a volunteer with Cooperation Humboldt in many situations. These folks, we need to support them. They're competent. They are really familiar on a face-to-face basis with the homeless segment. And so I think it's urgent that we offer some support in whatever way possible to that program. And there's only one other comment that I have, and that is there are certain services that are quite limited under Uplift just because of funding. And I could be wrong, so please correct me. But it's my understanding that it falls a bit short because we were working under a grant where we were able to give supplies to homeless people. And Uplift did not have access to those kinds of very emergent supplies. That grant has since been expired. But in addition, it had a lot of some part-time employees. And if there's any way at all to expand the hours in that program, and somehow they do a tremendous amount of informal, but very competent case management. And if there was any way to implement ways to expand their level of reaching deeper into the community for case management, we should support it. And then as a very final thought is, please correct me if I'm wrong on this, Mr. Rosen. It is not countywide. The team that I observed over the period of a year was based in Eureka, but I don't know that the Uplift services are in Arcata or other parts of the county. But if not, that program, boy, it would be valuable in getting it further out of just Eureka.
Uplift really does do tremendous work. I appreciate the comments, and I'll make sure to pass it along to the team. To speak to the efforts in expansion, the city of Eureka is looking to expand in a couple of ways. One, in expanding Uplift's capacities by better funding that program, so that they can hire more street outreach as well as more supportive services staff and housing managers. Then the city's also hired me to begin and start the Crisis Alternative Response Team, which is going to be the city's own mental health team that responds in collaboration with Eureka Police Department. We will have case managers that go out and do more of that deeper case management That's a little bit more than what the Uplift street outreach folks are doing, with the goal of kind of playing that system navigator, making sure that people can get to the resources that they need to get to. Both of the programs are incredibly heavily grant funded. You know, without grant funding, they would not exist in the current function that they're in.
Okay,
With regards,
I want
sorry,
to
go
kind
ahead.
of to jump in here, and part of that is we have an ongoing discussion of request for something without a motion. I just want to say, Dennett, I've seen your hand up. Is that by accident, or did you want? Okay, I see you saying no. Okay, and then I did see Debbie wave at me.
Well, Tim, I'll move that we have a special meeting to decide on this letter idea and have a Zoom meeting. I suppose it has to be noticed though. So I was going to say, why don't we just have it after we end this meeting? But I suppose we need to notice it to the.
Yeah, I think we could easily just do a little straw poll, but we can't vote on anything, but we don't need a vote on that anyway. Tim, you set the agenda and you can call an emergency meeting, which would allow us to do it more quickly.
Yeah, I know. You know, I'm just asking what we want to do it. We're going to have to go through all the legal protocols to make it happen. And I'm just wanting to hear if there's a vote to do this. Katie, this is a board discussion about board procedures. Laura, I see your hand up.
I'm just saying, I support Debbie. I second, I would like to have an emergency meeting to support this very important, effective program.
Okay, that motion, Joe, did you get something about that? Can you read a motion back to us so we understand what we're voting for? Joe?
Can you say that again?
A motion was made and seconded, and I just wondered if you can read back to us what that motion is.
I didn't get that. Can you tell me what the motion is? To have a second meeting? To have a special meeting?
What I heard is to have a special meeting to relate to the recommendation that was mailed out to us for supportive letter. I'm stumbling with it too. Is that close enough, everybody?
That's close.
Tim. Hey, Tim, can we cut to the chase? Is there anybody on the board who would be unable to attend or opposed to having a special meeting next week on the writing a support letter?
So Tim, we have a motion on the floor. And so I would say that's a substitute motion that you would like to vote on. Is that correct?
Well, we cannot vote on anything per the Brown Act. We can ask people informally, do you have an objection to meeting next week? Because there's no point in Joe doing the work to set it up if people can't make it, you know, or they don't want to do it. So if everybody kind of nods their head and says, okay, we'll do that, we're done. You can tell Joe to set it up and we'll do it.
Okay.
But we can't vote on, do a formal vote.
Yeah.
Right. Got it. You're right. You're
Can
right.
I request that it's on Monday or Tuesday?
Well, that was the next thing I was going to do, Alyssa, because I need to send out a recommendation time for this meeting would be a short one. So everybody just nod your head or raise your hand if you would like me to call a special meeting. But I don't know if you're watching that, Joe, to see. It seems to me we have most of our board members agreeing to do that. Okay, thank you, Allison, and the rest of you. Thank you very much. So that's what I will do, and I will work on it this afternoon to ask people for what's the best time to do that and get back to me. I'll also make sure everybody has taken a look at that letter. I want to recommend that to you. But all right, that's where we're going to go from that. Thank you, Laura, and thank you, Jacob.
Thank you, everyone, for your flexibility and moving on that in short notice.
Yeah, we want to do the best we can to do that. So, Katie, I saw your hand up.
Yes, I just wanted to ask Jacob whether individual letters would be helpful. And if so, maybe if he could email me the specifics. I know I did get and looked at the letter itself, and I think I'm totally happy to support that. But if it would be useful to have individual letters from people in the community, if Jacob could let us know.
It certainly would, Katie. I will drop you an email with the details. Thank you.
Perfect, thanks.
Okay, thank you. Are there any other communications from board members? Hearing none, we'll move on to the item number 8. These are reports. I don't see that Connie is here with us, so I'll go right to you, Emmy.
Okay, thanks. The only thing I thought I would share today with the board is just kind of an update on some of the conversations around the local behavioral health triage center that we're doing in partnership with the EDs and others. Paul and I, over this past week, traveled to Orange County to look at their Be Well facility, which is what they use locally to create opportunity for people in crisis to come and get triaged and have some stabilization opportunity, both for mental health and for SUD. So we traveled down, like I said, Paul and I, along with staff from both Providence and Mad River, and Ruby Bayan, Dr. Bayan from Waterfront Recovery Services joined us as well. So it was a good trip. There was lots to learn. The conversations will continue. There were absolutely no firm decisions made, but it was really great to be able to see their facility, hear the things that work, the benefits of it, and also the challenges, to give us something to kind of use as a starting point for conversation around what might be helpful here in our community. So more to come on that for sure, but I just wanted to let you know that we did get that opportunity to see Be Well in Orange County.
Thank you. I appreciate you and the whole team moving forward to find a good answer to the challenges that we have in that area. Jack, is there anything more to say about the AOT update? Just a brief one. What's going on?
Kind of status quo from last time we checked in. We still coordinating with EA on that and sending referrals their way, and a lot of them continue to be in the outreach and engagement phase. There's a couple of clients who have voluntarily agreed to participate in services, and then one client that we're going to go to court with shortly. So we're going to start that phase of it, but that's about where we're at. Still at 7 clients in the program.
Okay, thank you. I see Tim Ash's hand up, and I see Debbie's hand up. Tim.
Yeah, I had 2 things, a comment and then a question follow up for Emmy. I just want to recognize that Jack and Nicholas and Daniel from EA attended our last NAMI meeting and gave us a presentation on what the program is and how, as family members, we can be part of the process. And anyway, we appreciate that. It was a good presentation. Anyway, the follow-up question, Emmy, on the Be Well, you mentioned triage and stabilize. I'm just curious what the status at their program, what the status, like per 5150, are they on holds or not on holds or both? Or
They had, I think, 7 different service type, 5 different licenses, and they had a variety. So I think it was, and Paul can help if I'm getting any of this wrong, but the CSU was a designated location for people on holds, but then there was also opportunity for them to be moved to either SUD, crisis response, or mental health crisis response, or dual recovery, or like co-occurring crisis response and treatment. So yes, there was a portion of it that was for 5150 holds.
Cool, thank you.
Thank you. Debbie, I saw your hand up.
Yeah, I appreciated the presentation as well for the NAMI board. And I looked at the webpage with the referral letter or form that somebody would fill out. if they wanted to refer someone to the program. It's the webpage of the agency that's doing the program anyway. And so what you do is you fill out the form and then you email it to them. And I was just wondering if it would be possible to have another method besides emailing that form to them, because just of my leeriness of electronic, the way things can go to the wrong place and the wrong people and so forth. Not that, I mean, probably 99% of people don't feel that way, but maybe like here you have this form and it has all this confidential information on it about somebody you might be referring, and you send it off into the ether. And just from my point of view, that's a little scary. So I just maybe look at that and put some kind of mailing address so you could mail the form. I trust that more than emailing, is a thought that I had.
Jack, you got a response to that?
I think that we try to make it as easy as possible so people could just call or ask, to have somebody reach out to them, and then we could just, do it that way. I think the form, I really think is like, it's nice if people want to do it, but I recognize that, it might just be a phone call or,
Well, the phone call, that you're right, that's a good option too. Okay.
All right, thank you. Our next item would be committees, various behavioral health board committees or ad hoc committees. It's your chance to touch base and communicate with us. Okay, then we're getting close to our time. As the chair, I just want to say we were going to do this meeting in person. If you all remember, we sent that out, and we're going to do it in person. But executive committee realized that we need to do a run through, and we have questions about masks and different things, but pretty much about the technical aspect of it. So here's what's going to happen. So the executive committee is going to do a trial run in January, and I'm pretty sure that we can be in person at the Behavioral Health Board in January. Again, it'll be a hybrid meeting, so that if people want to or can't able to actually be in person, they'll be able to participate as well. Any questions or comments about that? Yes, Alyssa.
Will we be sent a notice like when we get the invite normally for the executive meeting, it comes through the email? Will the information for where we meet and what time be on that invite, letting us know that we can participate in person or on email? I mean, or online?
Yes, thank you. I'm pretty sure we will, but that's a reminder to me. Yeah, well, you let everybody know about it.
Okay.
And since you're are you the third vice or the second vice chair?
I'm after Laura. I don't know that. I think I'm the second vice chair.
Oh,
Is there a
okay.
third?
Yeah, you're the second. Okay.
Okay.
Thank you. Remember, other people can join us for that meeting. Any other comments or questions about our in-person meetings? All right. Thank you. Vice Chair, do you have anything to bring up? It says on the minute you can say something you would like to, Laura.
Well, I did talk with Danette, and she agreed that she would co-chair with me the SUD committee. And so I just wanted to say that I'm excited about that, and hopefully we can make that happen moving forward. So thanks, Danette. And also thank you to all the staff that show up for this meeting every month with your shiny faces. I appreciate you. Everyone appreciate it.
Yeah, well, 9 out of 10. So thank you, Laura, for that. Also, Laura and I are going to be interviewing a person on Friday like a good candidate to join us on the board. All right. It's kind of in our agenda to do any other things about the care court or the navigation center as an ongoing unfinished thing. I see Karen Wolf is not with us. There's nothing really new about the care court or the navigation center. So Tim.
Yeah, I'm just curious, is the person you're interviewing the 15th member or 14th? I never can remember that, where we're at.
Would be the 15th.
Okay, I just want to throw out, I don't know if the executive committee meeting we talked about a TAY representative, and Jeremy, you're going to check in with Sonia. Just wonder if there's any more on that, because that's kind of closing the door for that for now if that person was put on the board and there were no other applicants.
We have
a comment,
applicants.
Laura.
I am constantly recruiting for TAY, just so you all know, and there has been no one.
Well, I did want to comment on that. I've always understood a TAY board member is someone who is a part of the TAY program, either volunteer or participant. Is that your understand, Sonia? Or am I wrong on that?
I think historically, it's been like a HCTC Youth Advocacy Board member has participated on the Behavioral Health Board. I think there's been the idea that there's 2 spots designated for TAY youth. It doesn't have to be an HCTC Youth Advocacy Board member. It could be any TAY aged person. I think part of the recommendations that several of the young people gave about a year ago was that you recruit outside of just HCTC to fill those spots, along with several other recommendations that I think our young people feel like haven't fully been met, and so that the space isn't a place that they feel like they have the capacity or energy to put into at this time. I don't have anyone specific on our board right now that has shown interest in their leadership plan that they want to participate or be on this board currently.
Okay, thank you, Sonia. I see your hand up. Tim, you have a follow-up comment or question?
Yeah, I was just kind of, I was going to agree with Sonia as far as the person doesn't have to necessarily be part of the TAY program, but I think it's important for us to broaden the outreach in the community to try to get, if we have 2 youth, that at least one of them be someone who really has some experience in the system, foster care system, that kind of personal lived experience. That's my only comment about TAY, not just that they're 18 to 26.
I think so too. I'm very interested in a new possible board member who has been on the board before and has a lot of experience on some of the issues that the Behavioral Health Board focuses on too. So one time I thought maybe we could ask to expand the board, and we basically said no at this time. So so that's kind of what we've discussed about, and I think we can continue. Sonia, I see your hand up.
Yeah, I mean, I think it's important that there's at least 2 spots for transition age youth so that they're not feeling tokenized as the representation for that entire age range. And I think really recruiting outside of TAY makes sense too, that anyone with lived experience. I think there's also been conversation, maybe just I need a refresher on my clarity, that peer coaches could sit on the board even though they're staff, but because of their lived experience in that job classification. So that might be another place to look, is at our peer support in the county, and if there's anyone that fits.
Thank you. Dimash, you put your hand down. I think that seeking people with lived experience or connection to mental health services in general is always a good idea. Any other communications from committees or ad hocs? All right, we're about there. There's really nothing to say about the navigation center that's new. Is there, Emmy? Nothing new? Okay, any future items we want to be, also agenda items, please let us know. Paul's going to be with us in our January meeting as a presentation about quality improvement. And if you have other agenda items, presentations you would like, then let us know. Alyssa, I saw your hand up and then went down.
I was just getting excited and wanted to say happy holidays to everybody.
No, that is worthy. We're at that close and end of the committee. Katie, I see your hand up.
Oh, just to remind the board that I was interested in having that letter I wrote be added to the agenda, a future agenda, since you're out. Yeah.
Thank you for reminding us on that. Joe, can you put that in for the executive committee as a reminder that we don't forget that, okay?
Thanks so much.
Thank you, Katie. Any other holiday wishes? Any other gifts you want to send me? Seeing no desire to send me anything, then I want to adjourn this meeting until January. All right, everybody, take care. Have a good holiday season. All right, bye-bye.